It's only by empowering clinical researchers will we actually realize the true potential of the AI. Because I think if you leave it to computer scientists and to engineers without wanting to be derogatory, they may still just focus on the same tasks and optimizing the same tasks. Whereas I think healthcare professionals will quickly learn and identify many novel indications for developing and applying AI systems. That's the phase that we could be entering into now.
That is Dr. Pearse Keane. He's a consultant ophthalmologist at Moorfields Hospital in London and NIHR clinician scientist at the Institute of Ophthalmology at University College, which is also in London. Back in 2016, Dr. Keane was responsible for starting a collaboration between Moorfields and Google DeepMind. The goal is to apply machine learning to OCT image analysis. DeepMind Technologies was founded back in 2010 and is now owned and operated by Alphabet Incorporated, which is the parent company of Google. DeepMind created a neural network that learns things like how to play games and video games. The company also partnered with the Cancer Research UK Centre at Imperial College London, aimed at improving early detection. Dr. Keane said that the future of the application of AI has challenges.
There are a number of blockers to its actual development and implementation. And so you've got three main things. You've got the fact that you need very large data sets, the fact that you need a lot of specialized technical expertise, and the fact that you need a lot of computing resources to be able to train these deep learning networks.
This is Medicine in the Machine, an information and conversational podcast from Medscape about how technology is impacting medicine now and how it will in the future, featuring hosts Dr. Abraham Verghese and Dr. Eric Topol. I'm a producer on the show, Nick Andrews. In this episode, Dr. Topol and Dr. Verghese welcome Dr. Pearse Keane to discuss how his work is going and where it's headed next. Please welcome Dr. Abraham Verghese and Dr. Eric Topol.
I'm Eric Topol, and with my partner Abraham Verghese, we bring you the next podcast of Medicine and the Machine. And today we're really delighted to have Pearse Keane, a leading ophthalmologist at the Moorfields Eye Institute in the UK, as our guest. So welcome, Abraham, of course, and Pearse.
Thank you.
Thank you, Eric.
So Pearse and I got to know each other from the NHS review that occurred over the last couple of years. And I had the chance to have an eye exam with Pearse at what I believe is the most prestigious eye institute in the world. And so Pearse brings with us, to us, a lot of perspective about the use of deep learning and AI with a unique program that Pearse and his collaborators started some years back and they are continuing to build on it. So maybe you can summarize, Pearse, what you've been up to, because it's nothing short of remarkable.
Thank you, Eric, for that. So I guess the summary would be that for those of the listeners who don't know, I'm a consultant ophthalmologist. So a consultant in the UK system is kind of like an attending, I think, in the US system. So I'm an ophthalmologist, an eye doctor who works in Moorfields Eye Hospital in London. And Moorfields Eye Hospital is the oldest eye hospital in the world. And I'm also a clinical academic at the Institute of Ophthalmology at University College London, UCL. And so for many years, I've been interested in the potential of new technologies and innovation in healthcare. And so, of course, in that regard, have read many of your books, Eric, even before I was privileged to meet you. And so, I have always felt that ophthalmology is one of the most technically driven and technically advanced of all the medical specialties, going back to the 1950s when you had the introduction of laser for treatment of diabetic retinopathy, to the 1970s and 80s where you had use of ultrasound to remove cataracts through kind of micro incisions, and even more recently when we've got a lot of gene therapy and stem cell therapy being done in the eye. So it's really exciting to me that ophthalmology also seems to be, at least I believe, at the forefront of the development and application of AI. Now, that's also exciting, I think, because there's a huge need in ophthalmology for new technologies and innovation. And so, some people, perhaps even some doctors and other medical specialties may think of ophthalmology as somehow being like a small medical specialty or a niche medical specialty, but actually it's one of the busiest of the medical specialties. And so for example, in 2017 in the UK, ophthalmology overtook orthopedics as the #1 busiest of all the medical specialties in terms of clinic appointments. So nearly 10% of all clinic appointments in the National Health Service of the UK are for eyes. And that's a number that's grown by more than a third in the last 5 years, as we have an aging population, as we have increasing prevalence of diseases such as diabetes. And the unfortunate reality of that is that there are some people that lose their sight, that go blind, because of delays in being seen and treated by ophthalmologists and specialists like myself. And so it felt to me, particularly given how image-driven that ophthalmology is, that artificial intelligence, and in particular deep learning, would be particularly potent in this specialty.
Stay with us. We'll be right back with Medicine and the Machine.
You can read the transcript from this podcast and find more Medicine and the Machine episodes at medscape.com/machine. Medscape news, features, clinical tools, and education are available for free. Stay on the pulse of medicine. Visit medscape.com.
What's different about the U.S. is that you do a optical coherence tomogram on each patient each year there, and you have a wealth of data that is unmatched, as far as I know, to be able to apply deep learning. And I guess you had the foresight of developing a deep, if you will, collaboration with DeepMind there, and took us forward about this, the paper you had in Nature Medicine of triage of over 50 different eye conditions, acute eye conditions. That might be worth summarizing briefly.
Yeah, so I mean, we ophthalmology, not just in the UK but all around the world, is now dominated by this type of imaging called OCT, or optical coherence tomography. And OCT is like an ultrasound, but it measures light waves instead of sound waves, and it gives very high resolution images. And one of the things is at Moorfields is that we do huge numbers of OCT scans. So even though an OCT scan is higher resolution than an MRI scan or a CT scan, and it's a three-dimensional imaging modality, we do about 1,000 OCT scans per day. And so huge amounts of data. What was happening then, of course, as I've already explained, was that we have this huge challenge to see and treat all the patients in a timely fashion. And I should emphasize that this is not just in Moorfields and not just in the NHS, but across the world in general. Ophthalmology is standing room only in the clinics. And so what happened was, I had a patient with age-related macular degeneration, or AMD. Her name is Elaine, and she's talked about her condition publicly, and she was in a situation where she had lost the sight completely in her left eye because of the severe form of AMD called wet AMD. And then in about 2012 or 2013, she started to lose the sight in her good eye. And she went to her local community optometrist, who told her, you know, I think you're developing wet AMD in your good eye. But there's a treatment for it now. We can give you these injections of these, anti-vascular endothelial growth factor drugs into your eye, and it can stop you from losing the sight. You need to urgently see a retinal specialist in a hospital. Now, Elaine then went to her family doctor and got this urgent referral, but she got an appointment 6 weeks later. Now, you can imagine a situation if that was a family member of yours. I mean, if it was my mother, I would want her to be seen and treated in a few days and not in 6 weeks. Now, as it happens, Elaine was able to get seen and treated in a timely fashion, but it was that single sort of exemplar that made me think, why don't we use deep learning and apply it to OCT scans to prioritize those patients with the most sight-threatening disease, so that we can get them in front of someone like me or my colleagues as soon as possible. And so with that being the case, in about July of 2015, I approached the company DeepMind, and I said, I'm a consultant at Moorfields. We're doing 1,000 OCT scans per day. There are people who are losing sight because they can't be seen and treated quickly enough. We should apply deep learning. We should work together to apply deep learning to these scans. And by the way, we're 2 stops away from you on the tube, on the London Underground. So this could really facilitate a collaboration.
Yeah, no, and the fact that you could not even miss in thousands of OCTs with the algorithm, one acute triage in 50 different conditions. And I know you're going forward with that prospectively, and it's really commendable that you're doing such rigorous work. Now, what I thought was especially relevant to discuss today, because this whole medicine and machine story, is the paper you recently published about doctors who had no initiation with AI working with these tools, which was stunning with respect to how facile, quickly the uninitiated doctors that you work with could achieve this.
So this is the project that I think I am most excited about in the longer term. And so as I've said, I have been working with DeepMind and with Google for nearly 5 years from now, and in the course of that collaboration, I've always been a little bit in awe of some of the computer scientists that I was able to work with at DeepMind, and I always felt not envious, but a little bit sad that in the course of my long, interminable medical training, that I never had an opportunity to do some really dedicated machine learning and data science. Now, with all of that being the case, with deep learning, there are a number of blockers to its actual development and implementation. And so you've got 3 main things. You've got the fact that you need very large data sets, the fact that you need a lot of specialized technical expertise, and the fact that you need a lot of computing resources to be able to train these deep learning networks. Now, what I was very excited about then was in 2017, when I read an article in the New York Times, which was called Building AI That Can Build AI. And it described these automated deep learning platforms, which allow people without any coding experience to develop deep learning systems for tasks such as image classification. And so when I saw this paper, it was just like this eureka moment, because it was finally an opportunity to begin to explore these, this area without the kind of intermediary of the scientists at DeepMind or other computer scientists or engineers in an academic setting. And so we immediately got the idea of getting publicly available medical image data sets from all around the world and using them on these automated deep learning platforms. And so we did that because we didn't want to have to, we did it because we were appropriately cautious, I think, with not wanting to use images from our own institution without going through a rigorous approval process. So we tracked down data sets from skin cancers, from chest x-rays, from OCT scans, retinal photographs. And the amazing thing was that we were able to get results that were comparable to state of the art in just a few days. Now, the reason why I think that this is exciting is because I think that this is a big step towards the democratization and industrialization of deep learning. Because, you know, much as I think the people at DeepMind and, you know, in other academic settings are very smart, I think that healthcare professionals bring something special to the mix. And I think that it's only by empowering clinical researchers will we actually realize the true potential of the AI. Because I think if you leave it to computer scientists and to engineers, without wanting to be derogatory, they may still just focus on the same tasks and optimizing the same tasks. Whereas I think healthcare professionals will quickly learn and identify many novel indications for developing and applying AI systems. And I think that's the phase that we could be entering into now.
This is fascinating to hear. And I wonder, linking this to our previous discussion on behavior, have you had to deal with pushback and resistance from rank and file ophthalmologists or perhaps physicians in practice as you try to implement things like this?
Well, I've been giving talks about AI-enabled healthcare for a number of years now, and it's very common that the question that comes up at the end, no matter how reassuring you are, the question is, will AI replace doctors? Or will AI replace healthcare professionals? And there's various different answers that I give to that. Now, what's interesting with these automated deep learning platforms is that when we were publishing the results of our work with this, which we published in the Lancet Digital Health in September of 2019, the editor of the journal, in the course of the revisions, said something to us like, we hope you will make it clearer that these platforms will not necessarily replace AI experts in the future, something like that. And so when I read that, I couldn't help but smile a little bit, because of course this is the same question that doctors have had to face for a number of years. And of course, I really don't think that it's a question of people being replaced. I think that there are tasks that will be made easier using these technologies. And the other thing I would say is, to expand on that a little bit, there is pushback from machine learning experts about the use of these platforms, and I think it's worth highlighting some caveats about these platforms. And the first is that, you know, no one is suggesting that you could use these systems for direct clinical care anytime soon. So there is a huge amount of validation that's required and careful testing that's required for even state-of-the-art bespoke deep learning and other AI systems. And that will even be more so in the context of automated deep learning platforms where you know, healthcare professionals are beginning to develop them. But nonetheless, I can imagine lots of like clinical research applications that we can start to explore with these tools. So for example, in ophthalmology, in ophthalmic research, it may be very common that you might be given a data set of like 10,000 retinal photographs, but you don't know whether they have a label of being a right eye or a left eye. And commonly what you would do is you'd have like a medical student look through all 10,000 scans and label as a right or left eye. But now we don't have to do that. We would just train a model which could tell the difference between the two. It takes a short period of time, and then we have something that's useful in terms of the research. So what I could imagine is that in the same way that statistical software that became available in previous decades empowered clinical researchers, I could imagine these tools doing something similar, so that, for example, if I have an idea, I might sort of do a very sort of initial feasibility with one of these tools. And if I see some signal there, then perhaps I then start to work with, more people with more specialized expertise in taking the next steps.
Right. I think you're highlighting a number of things just to review, Pearse. Firstly, that by having these automated modules that healthcare workers can play with and learn from, it's a remarkable educational tool. And that democratization is, I think, something that could be part of the curriculum for medical students and training and throughout the profession of the healthcare workforce. But the other thing that you're touching on is kind of interesting as well, because if you talk to statisticians, their worst nightmare are researchers that use StatPack and come up with flawed p-values. In a sense, what we've got now is a similar, more advanced state. I mean, essentially, all AI is a math story, and now the fear. And I hadn't heard this before, the backstory about the editor, which is fascinating. The fear that the AI people could be replaced, but that gets us to the thing that I get disturbed about the most, and I think Abraham and I have touched on this in the past, and that is, why is it always pitting, the doctors, clinicians versus the machines, when what we really are after is the fusion of efforts? And there seems to be this relentless kind of, the deep blue chess match that it just is unstoppable, and it keeps recurring in all the publications. And why is this such a fixation?
Yeah, I'm not sure. I mean, I think it's human nature that, like maybe an analogy might be in terms of political, reporting. It's maybe it's difficult to keep people focused on policies, and it becomes sometimes about personalities. But I think one thing that struck me as you were saying this is, we also, I think, can lose track on the reason why we're doing this, which is for patient benefit. And so, ultimately, I would say if something produces better outcomes and is better for our patients, then it should be irrelevant whether it's a human or a machine or a fusion of the two that achieves that. And I think that has to be our kind of North Star in this regard.
As you look to the future in your field, I know you said that this is not going to replace the interaction, but it certainly might modify it. As we spend more and more time on Zoom, it seems to me that some specialties, and perhaps ophthalmology is one of them, might allow for screening in a way that we would have had to do in person before. Do you see new horizons as we evolve our technology, evolve our ways of, treating patients at home, which is what we're doing right now? So many of our visits are by video, by phone call.
Well, I think, if it's not inappropriate to say it, I think that certainly there may be opportunities to, explore new ways of working and accelerate some new ways of working with the challenging times with the pandemic in the coming months and longer. I think that there's probably two aspects to the way I would see this. So the first is that there are many aspects of healthcare that are, really should be consigned to telemedicine or to some other kind of remote monitoring type processes. So in my field of ophthalmology, if you're diagnosed with glaucoma and it's picked up early and you're being treated with drops, you're typically going to be fine. You have to be monitored for the rest of your life. But is it really necessary for you to come in every few months to the crowded hospital eye service and wait for a long period of time for a very short consultation where you're told you're fine, we'll see you in 6 months' time? Or are there better ways that we can do it? And for me, the promise of AI is around how we can bring world-leading expertise into the community and into people's homes and overall improve their experience. But of course, the flip side to that is that there are some aspects that I don't think should be replaced, or that the human interaction should be downgraded in some way. So, for example, I could never imagine a situation where your smartphone or your smartwatch tells you that you're going to go blind, or that you've got cancer or something like that. I think you would always want this kind of human interaction with a healthcare professional who's experienced, has been through the process, and who can kind of help to guide you along.
I was just going to ask you that exact scenario about, being able to communicate to a patient about the inability to prevent the blindness and the serious matters that require the human connection, the human touch and empathy. And I think you really already anticipated that question. So I think this has been an important discussion. I look to you, Pearse, as one of the most careful researchers in the AI medical field, because you avoid any hype. You go after things, not just first retrospectively, but then you do the right types of trials. And you've taken us to new frontiers with respect to how to educate the healthcare workforce with the AI to build AI theme that you reviewed. Mm-hmm. So it's terrific. And we're so glad to have a chance to have this conversation with you. And the other thing I would just add, Pearse, is the best of both worlds. The idea that you sought after a very able collaboration from the DeepMind folks in the UK, which helped enable the progress that you've made, and in many ways have shaped the arc of your ongoing efforts. And I think that's something else that we have to keep in mind, that it's not so easy to accomplish these just in the academic circles, and having the ability to tap into resources from the tech world is extremely helpful as well.
I would just add that what I've learned from the last few years is that really to make a lot of progress and to drive innovation, you have to have collaborations that are at the boundaries of different disciplines and at the boundaries between industry and academia. I believe that's the way to make real progress.
Yeah, and it shows, because the three of us are not computer scientists, and here we're talking about it, and we're learning about it all the time, every day. Thanks so much, Pearse, for joining us, and Abraham, and we look forward to the next time we can convene for a Medicine and Machine podcast.